Thank you, Dr. Umar, and I'm especially grateful to Dr. Aisha, Dr. Tahir, and Dr. Umar for this opportunity. This session is a joint session of Pakistan Endocrine Society and South Asian Obesity Forum. So, as an executive member of both the Pakistan Endocrine Society and South Asian Obesity Forum, I welcome you all to this session. Without further delay, I would request for the welcome note and an introduction to South Asian Obesity Forum. I would request Dr. Musarrat Riaz. She is Professor of Endocrinology at Dow University of Health Sciences and Director of National Institute of Diabetes and Endocrinology in Karachi.
Thank you so much to the Pakistan Endocrine Society, and thank you so much to all of you who are present here. It's my honor to introduce South Asian Obesity Forum to all of you, and why we are working on it and how this is a session in Pakistan Endocrine Society. So basically, SOF stands for South Asian Obesity Forum. It's a consortium of experts from 8 different South Asian countries, which includes Pakistan, it's India, it's Bangladesh, Sri Lanka, Nepal, Mauritius, Maldives, and Afghanistan. So basically, I don't need to tell all of you why we should be concerned about obesity, why we need to talk about it. We all know why it's important and what it's doing. So again, the term diabesity, we all know, we are all familiar with it. Just shows to emphasize that whenever we think about any chronic disease, not just diabetes, we should always be thinking in terms of obesity. So there's a need that obesity should not get hide under so many other conditions that coexist along with obesity. This region, South Asian region, where more than half of the population with diabetes and obesity resides. And as per data from our part, around 75% of our population is either overweight or obese. So it's a big problem here, and we know the numbers. Dr. Amir has just elaborated about diabetes. We know we are ruling the world as per the percentage of people affected with diabetes. And obesity, the problem is it's not just the grown-up people. It's more now common in our children and young people. So there is a need to talk about obesity at every forum, to deal with it and do something about it. So global prevalence of obesity, as I've said, not only in the adults but in the younger age group, it's continuously increasing. If you look at the data from 1975 to what is expected in 2035, it's continuously on the rise. So if we don't do anything right now, this number is going to increase, just like we see in diabetes. Number of diabetes, people with diabetes is more than what was expected 10 years back or 20 years back. If you look at the previous IDF atlases, whatever they predicted, it's all been proven wrong, and there is more and more of these people. Same applies to obesity and overweight. So again, the likelihood of all diseases, not just diabetes, you talk about cardiovascular, you talk about hypertension, you talk about mental health illnesses, everything there is part and parcel of obesity. And I think the time has come that we should be thinking that obesity maybe is the common soil from which all these diseases are emerging. Rather than saying obesity is part of it, obesity may be the core problem that underlies all these problems. Again, causes multifactorial. It's not just eating too much. It's not just doing less physical activity. There is a whole science beyond it. And we should be looking at it as a holistic approach, not blaming someone. We need to change the mindset. So there's a case of prioritizing our obesity-centric approach. This is what we are going to talk about, and this is what we are going to look at. And we all know that losing weight helps directly or indirectly in all these things. So why we consider about why South Asian Obesity Forum when there are so many organizations already working? You know, there are internationally, if you look at it, there are multiple organizations. Almost every country has something like that. Then there is International Society of Obesity working on it. But the problem is all these societies, they look at the wider approach, and the people living in Southeast Asia, South Asia, they've got certain things that are different. Their pathophysiology, their implications, how to tackle it, how to go about it. So there was a big gap, that there was nothing specifically related to South Asian people. So this idea came from Nepal, basically, with other colleagues who were working together in different forums. So they thought about this platform and the name about this. And this is basically a scientific, it's a non-profitable organization. It's a platform which is dedicated to improving the health of our people. You know, it's not just weight, not just obesity, but overall health. This is what it has done. And it was in the Sri Lankan Endocrine Society annual function in 2024, where the launch of the South Asian Obesity Forum was held. We had good representation from all the countries. From Pakistan, you can see Dr. Abbas Raza, me, and Dr. Sidra there. There are people from India, Bangladesh, Sri Lanka, Nepal, and all those countries who are part of this forum. So it was formally launched in 2024. And this is the tagline. You know, there is a logo, and when we were looking how to convey our message, there were so many slogans that come here: fight against obesity, fighting the obesity. But ultimately, the thing that everybody liked was united against obesity. You know, there are so many things in which we can fight with each other, but there are certain things in which we can be united together to look after this issue. So this is the tagline, official tagline of South Asian Obesity Forum, that we are all united against obesity. So let me introduce you the vision. It is to emerge as a leading professional organization in the field of obesity medicine in South Asia and beyond. So particularly in South Asian region, but the scope is wider, and in future we are going to collaborate with international societies as well. And it is, the main vision is to address the challenges of the obesity pandemic that we are facing, and to come out with the solutions in the region through, there are three core areas. Number one is education. You know, everything, every chronic thing, you can't do anything until unless you educate, not just the masses, your healthcare professionals, but the whole society as well. The second thing is research. Without local datas, you are nowhere in the world. So the second main thing that we are going to focus is research, and of course the advocacy. So these are the three main core areas that we are going to work on it. The scope and objective is manifold. There are 5 of them is written here. Is to improve the health awareness regarding obesity in the region. This today's session is part of that one, to raise the awareness among healthcare professionals, and we hope through this is going to mitigate to the general population as well, and to conduct various training programs for physicians, for awareness programs, general public, to disseminate and formulate region-specific guidelines that we all can work on it at the general practice level, family physician level, primary practice level, and to foster the multi-country research. You know, we are working on different projects, and to help in the policy and advocacy chains. So these are the core actions that we are going to look for: awareness, education, advocacy, accessibility, and availability. This is the official journal of South Asian Obesity Forum. Dr. Nitin Kapoor is the editor, and it's open. All of you who want to publish your opinions, your review articles, anything research, you can do that. And we had first International Obesity Conference last year in Nepal, again, with good representation from all these countries through media and press. This was done. There is presence in the social media, all these forums. The South Asian Obesity Forum is here continuously giving educational messages, videos. So in the end, obesity is not just a simple matter of willpower. It's a complex chronic disease that requires understanding, compassion, and comprehensive care. And treating obesity is not about changing bodies. It's about changing the lives, restoring health, and empowering people to thrive. So in the end, I would just like to say that we need to change our perception. We need to stop stigmatizing people, and we need to look at, from the scientific point of view, looking at the broader aspect. And in this regard, South Asian Obesity Forum is going to help all these countries, and all these countries are part of it. And every country who holds these annual conferences, it's now a practice to give a session to South Asian Obesity Forum. And I'm really thankful to Pakistan Endocrine Society because all the members are part of the Endocrine Society, and PES, not as official but unofficially, is part of the South Asian Obesity Forum. Thank you so much for your listening.
Thank you, Dr. Musarat. And as very rightly pointed out, it is time to come out of the cloaks and to shed that cloak of, hiding behind other disorders and bring obesity to the forefront so we can fight it. Uh, our next speaker is from Mauritius. Unfortunately, she could not join us today, but we have her recorded lecture today with us. Dr. Payal Bakurilal Chintaram is the consultant endocrinologist in Mauritius. If you could please have her talk.
Good morning, everyone, and everybody from the Pakistan Endocrine Society, their delegates and attendees. It gives me a great pleasure to present this talk on behalf of the on behalf of the South Asia Obesity Forum. So my topic is genetics and environmental links of obesity in Southeast Asia. So the prevalence of obesity in Southeast Asia is estimated to be around 5 and 20%. That too, when BMI is calculated as being more than 30 kilogram per meter squared. The prevalence of overweight and obesity is estimated to increase to 39% by 2035, thus posing a major problem for the healthcare settings of the region and can lead to increased prevalence of other cardiometabolic diseases. So behind the pathophysiology of obesity, we have a positive energy balance coupled with a genetic predisposition and strong environmental factors. To be noted, there are different kinds of obesity. We have syndromic, monogenic, oligogenic, and polygenic obesity. Syndromic and monogenic obesity, of course, are affected by a few genes that cause the issue, but the influence of environment is minimal. However, polygenic obesity, which is our topic for today, is heavily influenced by environmental factors. So the hereditability of BMI has been estimated to be between 40 and 70%. Monogenic obesity accounts for less than 1% of the cases of obesity. Many studies have been carried out, and there are numerous genetic variants that have been identified that are associated with obesity-related metrics. The obesity-related metrics that we are concerned are BMI, waist circumference, waist-hip ratio, body fat distribution. And only 5% of the variability in individual obesity measures can be attributed to these genes. So as you can see in this slide, these are all the genes till now that have been found to be implicated in obesity. Of course, in blue you have the ones that are related to monogenic obesity and are few. The highest number of genes have been found associated with BMI and then with body fat distribution. There are also a few genes here that we see that are associated with excess weight, be it overweight or obesity. So body fat distribution. There is a higher prevalence of abdominal and visceral fat in Asians, despite a lower BMI. Hispanic and African women, as we know, they have gynoid and pear-shaped body, whereas Asian women, they tend to have android upper-shaped body when they are obese, indicating that the distribution in Asian women tends to be central or visceral. These differences, they tend to be less marked in females as compared to males. So we must ask ourselves the question, so why do Asians have a genetic predisposition to store fat viscerally? And to what extent do genetics and the environment play a role in modifying the fat distribution. The majority of studies on the genetics of obesity have been predominantly carried out in Western countries. Therefore, these studies are highly powered to find genes that are pathogenic for these populations. There are fewer studies, but even then numerous, that have been conducted in Asians. And in these studies as well, the similar genes of obesity have been found. So there is not much of a difference in terms of, there are no new genes that specifically target Asians as opposed to other populations. Therefore, what is needed is a strong obesogenic environment for the phenotypic expression of obesity. So in one Pakistani study where they grouped around 4,000 individuals into 4 different groups, so BMI baseline, normal weight and overweight and obese. So they looked for the genes that were prevalent in excess weight. So the minor allele frequencies of 6 variants of the leptin receptor gene, the adipose gene, and the fat mass obesity genes were higher in obese individuals, and they were also strongly associated with overweight obese BMI. So, and what they also found was that some minor allele frequencies of 3 genetic variants of the CPT, FTO, and LP genes, they were higher in lean normal body mass and showed protection against obesity. Therefore, what is to be noted is that the genes for obesity, some variants can lead to obesity, whereas some variants can be protective against obesity. So, to try to determine what would be the cause behind the central obesity in South Asians, we need to look at whether there is some sort of genetic variation in this population. So a review was carried out that evaluated the contribution of DNA sequence variation to the higher levels of central obesity, so which means waist-hip ratio, among South Asians compared to Europeans. The genome-wide association analysis of more than 6 million genetic variants in more than 10,000 South Asians were examined, along with exome-wide association analysis of more than 250,000 SNPs in protein coding regions in 2,000 plus South Asians, and a comparison of risk allele frequencies and effect sizes in 48 known waist-hip ratio SNPs in more than 12,000 South Asians compared to Europeans. So they had a big sample, and they did a lot of analysis. And what did they find? Well, they did not find any association between the common genetic variants and waist-hip ratio in South Asians. Also, no association in the population-specific SNPs. No new association between between genetic variants and waist-hip ratio in the exome-wide analysis. Even for the known waist-hip ratio loci, the risk allele frequencies were not higher in South Asians compared to Europeans. So the conclusion of that study was that there was no important contribution for population-specific or cosmopolitan genetic variants that could explain the increased risk of central obesity in South Asians compared to Europeans, right? So, if the answer is not in our genes, could it be in our diet? Could it be gene-diet interactions? So we have this new field called nutrigenetics. So what is nutrigenetics? When populations with certain risk alleles, they undergo a change in their diet, the alleles lead to changes in body fat distribution. As you can see here, in Malaysia, they found that carriers of the COD-VDR gene, when exposed to low maternal vitamin D levels, they had higher birth weight. In Indonesia, um, uh, carriers of for example, the 5-SNP gene here with vitamin D genetic risk scoring, when taking excess carbohydrates, they had high body fat percentage. For example, low protein intake associated with 15 SNPs of cardiometabolic genetic risk scorings of more than 6 risk alleles. Those people had high waist circumference. Surprisingly, fat and coffee were protective against excess weight or body fat with carriers of the UCP gene. So this tells us that sometimes there are dietary exposures together with genetic exposures that can explain some metabolic processes or outcomes. For example, in this case, increased body fat percentage or increased weight. So this could be one potential explanation. However, I think the most important explanation, in my opinion, is the thrifty metabolism. So the thrifty metabolism, what is it? You've probably heard about it. So it is when people who have been exposed to periods of nutritional scarcity, they undergo their genes undergo changes so as to survive those tough situations and conserve energy. And when they're exposed to periods of plenty, of nutritional plenty, so these same genes, these same changes, this same thrifty metabolism causes them to gain weight in order to conserve more energy. So epigenetic changes have been observed in famine-exposed children, the Chinese famine of 1961, the Dutch famine of 1944-45. So when early life exposure to adverse nutritional events cause negative effects on the metabolism, and when shifted to an affluent environment, descendants of individuals of famine-exposed populations maintain the epigenetic changes that are responsible for ethnic differences in fat distribution patterns. Moving on to the environmental factors. So environmental factors probably play a very important role in the pathogenesis of obesity in the and it probably explains why there is a high prevalence of obesity. So since industrialization, what has happened, there has been increased availability of food in Southeast Asia. There are better transport facilities, so people are walking less. There is reduced physical activity, especially at the workplace, due to mechanization. There is increasing TV and phone and tablet viewing, so people are more sedentary. And there is increasing urbanization. Now, urbanization is a very important aspect of development in Southeast Asia. So more than 60% of the population in Singapore, Korea, Malaysia, and the Philippines and Indonesia, and more than 30% of the population in China, Pakistan, India, they live in urban areas. And not only urbanization, but there is also internal rural to urban migration occurring in these countries as people seek better livelihoods in the cities. So what happens is that there is physical activity that is decreased, increased BMI and upper adiposity, and there is easy accessibility to various diets with an abundance of refined carbs, processed foods, saturated and total fat, and lower content of fiber. And not only there is urbanization, but living conditions in the rural areas are also improving. As you can see in this study some years ago in India, where the use of, for example, of motorized transport, electricity transport was more than 90%. People have water supply that is accessible to their residents, that is near to their residents. They have medical facilities near to their residents. So therefore, people are walking less to access essential services. People are watching TV more. They are eating 3 meals a day, and they have regular access to the city. And also monthly income is rising as well, which so that people have more money to buy all kinds of food. So since industrialization in Southeast Asia, what has happened? People are consuming more fats, so they have increased in the proportion of dietary energy derived from oils and fats, mainly oilseed base that replace complex carbohydrate sources. People are eating more sugar, so increase in the proportion of energy derived from caloric sweeteners in Asian diets. For example, middle-income countries of Asia have increased their annual per capita sugar consumption from 12 to 31 kgs. Countries are able to import more products, so temperate zone fruits, vegetables, dairy, and other animal products. So there is an increasing homogenization to a more Western-style diet in Asia, and there is increasing potato consumption since the 1960s. And people are also consuming more wheat, so there is a shift from a rice-based diet to more wheat consumption. But this has been noted, especially in middle-income countries, whereas poor countries, the poorest countries, they tend to eat more rice. And also, the consumption of meat has also been increasing as part of the nutrition transition in Asia. So there is increase in pork and poultry consumption. For example, in China, the consumption of pork has risen from 15 to 31 kilogram per capita per year from 1990 to 2014. So how the most important dietary change, which encompasses the previous 5 changes, is the consumption of processed, packaged, and convenience food. So these foods, they're generally high in fat, salt, or sugar, and are scientifically designed to be hyperpalatable. So as you can see, increase in China and Thailand from the per capita consumption. So apart from change in the diet and urbanization, so what has come with development and industrialization in Southeast Asia is increased psychosocial stress. So there is increase in perceived stress from the industrialization in Southeast Asia. People are having to work longer hours to make a living. They have increased money, but they have to work more for it. There is fragmentation of families due to employment migration, and there is a crowded living situation. So it is still culturally wanted for families to be living together, for extended families to be living together, which means that, for example, women they need to care for more members of the family while also being in the workplace. So such conditions may also increase stress and contribute to stress-mediated abnormal fat metabolism. And so what happens there is the increased cortisol leads to increased fat deposition, and prolonged chronic stress leads to hyperactivity of the hypothalamic pituitary adrenal axis, and this leads to cortisol-mediated visceral fat accumulation. So, in short, the obesity in Southeast Asia is driven by genetic and epigenetic changes that are present in an increasingly obesogenic environment. So you have the genetic foundation for obesity, where Asians tend to store fat viscerally. You have the evolutionary history, where our genes predisposes to accumulate fat and conserve energy. Then we have all those environmental and cultural factors that are involved. There's urbanization, there's decreased exercise, there's change to a more Western diet, and there is decrease exercise and more sedentary lifestyle. So understanding the specificities of obesity for this population is key to finding solutions that can reduce the prevalence of obesity. So I thank you all for your attention today. I hope the talk was not too boring, and I revert back to the panel for further discussions. Thank you.
Thank you, Dr. Payal. And Dr. Payal is also with us online, and if we have any questions, Dr. Ali, if you could please join me for a few moments. And if there are any other questions for Dr. Payal, kindly scan the Slido QR code and ask them online. Dr. Payal is with us. Thank you, Dr. Ali.
Thank you very much for joining us in Pakistan. I mean, we are very pleased to have you here, and our audience love to hear about the obesity that you told about. What are the practical steps that we can take? 1, 2, 3 practical steps that we can take quickly to fight this pandemic against obesity. Are you getting my voice?
Yes, I'm getting. Can you hear me?
Yes.
Yes. Okay. So good morning, everyone. So thank you for your questions. So rapidly. So first of all, as Dr. Dr. Musharat has said, first important thing is education. You need to educate not only your healthcare professionals but also your population as to the risks and consequences of obesity. Practically, we need to pay more attention to whatever we are eating, and to specifically the type of food, nutrients that we're putting in our plate. And finally, we need to move more. It's the sedentary lifestyle is certainly playing a big role in the epidemic of obesity. So we need to get moving more, be it in our daily lives. It can be simple steps, just walk around more in the office, stand up more, get up from the chair, find some time to walk 10-15 minutes, 2 to 3 times a day, even if you don't have like proper time for exercise. But eat better, eat more quality nutrients, eat less calories, move more, and be aware of obesity and the risks and consequences of associated with obesity.
So, Dr. Ayaz from Karachi. I have a question from Dr. Payal. You mentioned in your slides, Arabian population is okay because of the high food calories and a lot of other things. But you also shown that in rural areas, because there is the nutritional imbalances. So, what are the reasons for their obesity is the main issue?
So, as we have seen in rural areas, the conditions are improving. Of course, there's still the imbalance where there are the poorest population still coexist with the ones that have more income, but there is generally better improving conditions in the rural areas, so people can afford to eat a more Western diet, and they're also walking less, for example, for going to work, for accessing facilities, and the fact that they're able to go to the cities more often, so you can have the influence of, for example, the fast food joints from the cities that or the different foods that are available in the cities are also becoming more available in the rural areas. So even though they are living in the rural areas, there can still be the influence of a more westernized diet present in those parts.
Thank you very much, Dr. Payal, for being with us. Although this time you were there virtually, but we would like to have you physically in one of our upcoming conferences. So thank you very much from all of Pakistan. Thank you.
Thank you for having me, and have a good conference. Bye-bye.
Thank you, Dr. Payal. Thank you, Dr. Ali Asfer. And I would now like to invite our next speaker, Dr. Azra Rizwan. She is consultant endocrinologist at Aga Khan University Hospital, and she's also vice president Sindh of Pakistan Endocrine Society, and she will be talking about individualized management of obesity.
Assalamu alaikum, ladies and gentlemen. I'd really like to thank the organizing committee for giving the opportunity to talk about management of weight issues in our region. So I'll be starting with the global scenario and the local perspectives. Then I'll be defining the various ways of defining the criteria for obesity in the South Asian population, when one should consider pharmacotherapy, the choice of medication. If you have time, we can go over when metabolic surgery is required, the bariatric procedures which have now become available in our part of the world as well, the goals of treatment, and then in the end, I'd like to leave you all with some take-homes. So this has already been covered. Obesity is an excess of fat that imposes harm upon the body and leads to uncontrolled hypertension, dyslipidemia, dysglycemia. It is one of the major public health issues that we are faced with today. And numbers are widely increasing in children, adolescents, and adults alike. This is a fairly recent nationwide survey in which the numbers are colossal, that basically central obesity was measured. Central obesity is the type of obesity that is very closely related to the metabolic syndrome, right? And it was found to be as high as 73.1%, with females being disproportionately affected. And so it's no wonder that obesity has been declared as one of the epidemics of the era. And there's a dire need for urgent lifestyle interventions to prevent this evolving tsunami. Now, getting on to the criteria for obesity, there are three main ways in which obesity can be defined. One we know since quite some time, that is the body mass index. And here, body mass index has been used for years, decades actually, for measuring weight. And we do that by measuring the weight in kilograms, and you divide it by the height in meters squared. And as you can see, the Asian cutoffs are 2 standard deviations less than our Caucasian counterparts. And the reason being Asians already puts you at a high risk for the development of cardiovascular disease and premature death. So normal weight is defined in Asians as a BMI ranging between 18.5 to 23, overweight when it's above that but less than 25. And then you have your various classes of obesity, where class 1, where increasing levels of BMI, and class 3 when BMI exceeds 30. So BMI basically has to be taken critically. We need to be critical when you talk about BMI, although it's very reproducible. It's what's been used in many randomized control trials to assess interventions. There is a downside because you measure the whole composition of the body here. You take into account the muscle, bone, and the fat. So as we know, the more the bone, the better. The more the muscle, the better. But fat, the less the better. So BMI cannot differentiate between that, right? This is where waist circumference is a better measure. And because it's a proxy for central obesity, the one that I talked about that was very closely related to cardiovascular disease. Cutoffs for Asian women is 80 centimeters, again, much less than the Caucasian counterparts, and for men, it's 90 centimeters, right? Hardly anyone is meeting these cutoffs, not even us healthcare professionals, but we should be striving to approach that as much as we can. Right, then this is at the extreme right are your more precise ways of measuring the fat distribution. And here you have the dual energy X-ray absorptiometry, the DEXA. Now, basically this, how this works is that there are some small X-ray emissions that kind of are able to compartmentalize the body into bone, muscle, and fat, right? So it's not widely available in all units. It's kind of timely and everything. So it's not something you can order in every patient. But yes, it has its use in research studies when you want to accurately determine the amount of fat in the body. Then you have your bioelectrical impedance absorptiometry. The DEXA, by the way, is a gold standard for fat distribution. Then you have your bioelectrical impedance absorptiometry. I will be showing you, it's a specialized weighing machine that I'll be showing you in a minute. And it works by sending small, painless electrical currents through the body. And in this way, it works on the principle that muscle and water conduct electricity very, very easily, whereas fat is resistant to it. So the BII, the more the resistance the BII can measure, that means the more the fat in the body. Then we have your hydrometry, which goes down to the molecular level and assesses the amount of fat and is beyond the scope of this talk, but you should know about it, that these are the various methods of calculation. So getting on to what is more practical in our setup. The waist circumference, people have used waist circumference with height ratio, waist-hip circumference ratio as well. But it's important to measure this accurately and also teach your patients to do it. If it's done accurately, it can be quite a useful tool for measuring, you know, what your, before your intervention, what the situation was like, and post-interventions, right? So to measure it accurately, you have to palpate the right iliac bone and the upper border of the right iliac crest and place a measuring tape around the abdomen in a horizontal plane at the level of the iliac crest, making sure the tape is parallel to the floor. And also the measurement has to be taken at the end of a normal expiration. So if this is practiced, it can be done pretty accurately. And that's when you'll be able to and also you have to make sure that the ends of the tape are not fitting too tight. They should be snug, but they should not be pressing on the skin of the abdominal wall. And this is the body composition monitor, the bioelectrical impedance absorptiometry that I was talking about. You ask the patient to stand on these electrodes, right, and firmly on them. You have to zero it like you do for any weighing scale. And this display unit has to be put up at 90 degrees with the arms extended. So it has to be placed at this position for you to get the numbers. Again, it's a good tool if you have it in your unit to assess the effect of your interventions. Now, before I dive into the management, when a patient with obesity comes to you, these are basically guidelines that a Canadian group came up with, but because they're so useful, it can be adopted, has been adopted across the globe. And it is important first, if someone presents to you, even if for a condition maybe not directly related to their obesity, and you see that they're overweight, you must ask their permission to discuss the weight because you know the future implications on their health, and explore their willingness and readiness for change. Then you need to assess the health status using parameters that I just mentioned, BMI, waist circumference. If you have the BIA facility, please do that as well. And identify the root causes for the weight gain. Then there needs to be advice regarding the risks of obesity and the benefits of even achieving a modest weight loss, that is weight loss below 50%, 5% to 10% of baseline weight. And then, of course, you need to set realistic goals. Of course, it's not feasible, practical for someone who's 100 kg to come down to 70 kg in the next 3 months. So this has to be agreed upon. And you need to assist with motivators, things that motivate the patient, and identify barriers to management that can be challenging. Psychological barriers, maybe our psychologists, colleagues would be of great help in this regard. Now, to quickly go, we went over all the genetic syndromes from our last speaker. And those are kind of rare it's very important to exclude hypothyroidism. Uncontrolled hypothyroidism can lead to weight gain, which is difficult to treat. And of course, your Cushing's syndrome. In addition to lifestyles, identification of abnormal sleep patterns need to be identified, very important when you're talking about weight management. Treatment is divided into three main categories. One is lifestyle modification, advice on adoption of a healthy diet on a regular basis, engagement in regular physical activity, cognitive behavioral therapy, pharmacotherapy, and then your metabolic surgical procedures. So basically, what kind of diet can you start with? A good place to start with is to advise a diet which is 500 kilocalories below the existing caloric consumption of the patient. So if you can achieve that, that can do wonders over the next 3 months. Portion control is key, prioritizing on non-starchy vegetables, lean meat, and high fiber diet. And as we talked about, restriction in processed foods, because during the process of the processing, the nutritional value of the product goes down and a lot of salt and a lot of sugar is added on the way. So this has to be restricted. This is to give you an idea of healthy plate. Almost half of the plate should consist of dark green salads and vegetables, as well as other vegetables. Whole fruit should be promoted. Fruit juices, even the homemade fruit juice, all the fiber goes out, sugars go up, and fat, triglycerides also kind of is phenomenally rise. Then lean proteins in the form of boiled eggs and white meat, lean meat basically. Lentils, red beans are full of iron, full of proteins, and your good carbohydrates in the form of whole grains. So this is what the advice should be. Now, where physical activity is concerned, although we all know it is fundamental for maintaining and achieving cardiometabolic health, exercise, the regular exercise that we usually advise, it does create a negative energy expenditure state, and the idea was that it would lead to weight loss. However, in many cases, that's not what happens because of certain metabolic and psychological compensatory mechanisms at place. So basically, except if you ask somebody, if somebody can exercise intensively for more than an hour a day, 5 days a week, that can lead to weight loss, but that is not practical for the majority of individuals. That is only a limited proportion of the population athletes can achieve. So basically, you need to give them practical advice of aerobic exercise such as brisk walking, 30 minutes a day, 5 days a week. That would help in weight maintenance, right? Cardiometabolic health and its exercise, achieving that cannot be understated. So when to consider pharmacotherapy? That is when your low-calorie diet, advice on that, consumption of high fibers and proteins, lean meat, in conjunction with a certified nutritionist if possible, because they're very, very good at coming up with diet plans which are not only healthy, but something that are more engaging that the patient can sustain on a long-term basis. Because all these crash diets like high protein, which are like keto diets, what happens when you go on a diet is your metabolic rate goes down. And if you go off that diet, then you will return to your state. Actually, you may end up gaining more weight than you originally started with. So you have to advise a diet that the patient can sustain on a long-term basis. That would be the diet that would be best for the patient. And also when engaging in regular physical activity, if that has not produced clinically significant weight loss, or the patient has been unable to maintain the weight loss, that's when pharmacotherapy should be considered in conjunction with your advice on lifestyle modification measures. It can be considered medical therapy early if a patient with the overweight state has associated difficult to control hyperglycemia, hypertension, dyslipidemia, and the notorious sleep apnea syndrome. So what should be the choice of medication? That depends on the extent of weight loss required. If someone is keen to bring their diabetes into remission, then they would require more than 15% to 20% of loss of weight from baseline. If they are doing it just to maintain their health, 5% weight loss would suffice, right? It all depends on the patient's comorbidities, preferences, and of course the cost of treatment involved. Now, before I delve into the actual medication, I'd like to pause to give you an idea of the medications that are associated with weight gain and alternative medications. For instance, a lot of our patients are suffering from depression, and a lot of these antidepressants do cause a lot of weight gain. So you need to collaborate with the physician who are giving these medication and ask them to possibly change them to an alternative with a lesser effect on weight gain, if possible. Yeah, neurologic agents such as valproate to control seizures, that leads to a lot of weight gain. perhaps the neurologist can shift them to lamotrigine or topiramate. We as endocrinologists see a lot of patients on high doses of insulin, and we always try to give them insulin-sparing agents such as SGLT2 inhibitors, the GLP-1 agonists that we'll be talking about, metformin, or weight-neutral agents like DPP-4 if they're not on GLP-1, in order to minimize the weight gain induced by insulin. So this is what the how it should go. So there are a lot of medications. I know this shows a Caucasian patient, but we see this kind of picture in our scenario. Steroids have been used sometimes for very good reason, but this is a patient who's probably been using all these topical steroids being given by 3 different dermatologists. And this is what has happened: relentless weight gain over 1 year. And this is a typical picture of what? These are Cushing-White features, basically, right? And so this, even topical steroids, the traditional teaching has been that the absorption is minimal, but if used over long periods and large volumes of the skin, they can lead to this. So steroids, this should be actually asked from the patient. Are there intraarticular injections that you're using? Oral steroids everybody knows about. Inhalers, topicals, as we said. So they need to be minimized, tapered down to their minimal possible dose. Now, out of the locally available weight loss medications, there's Orlistat, which has been available to us since quite some time. Initial studies there was an RCT which showed a brilliant 8% baseline weight loss. Thereafter, actually, most studies have documented an average of 3% weight loss, and this is what we see in our clinical practice, that it has the effect on weight with Orlistat has been mediocre in the majority of cases. It acts through inhibiting the pancreatic lipase enzyme, with the result that all the fats that are ingested are excreted through the stools. Problems, therefore, are oily spotting through the rectum, bloating, and because of the loss of ADEK, the fat-soluble vitamins, a multivitamin needs to be replaced at bedtime, at least 2 hours away from the Orlistat. Having said all that, there is a subset of patients who have benefited from it. That's my personal experience as well. So if someone is not willing for any kind of injectable, for instance, which is the only other effective weight loss medication we have here, then there's no harm in giving them a trial of that and seeing if they do respond. And within 3 months, we can always revise our decision depending on the results. Now, these glucagon-like peptide-1 agonists have revolutionized the management of obesity all across the world, and we are very lucky to have these available to us. Liraglutide is available as a daily preparation, is up-titrated in weekly increments. Semaglutide as a monthly preparation, up-titrated in monthly increments. Tirzepatide is not available locally presently, but I do believe it may be soon. It's a dual agonist for GLP-1 and GIP, and it is this dual agonist that tends to reduce appetite more than the single GLP-1 agonists. And it's the added GIP that has been thought to increase lipolysis and fatty acid synthesis, with the result that fat is preferentially burnt over muscle. So this is what we want to achieve, preservation of muscle mass. Now, GLP-1 agonists, the beauty is it can be given both in diabetes and non-diabetes individuals because they stimulate the secretion of insulin from the beta cells of the islets of Langerhans in the pancreas in a glucose-dependent fashion. Only when the glucose levels are high do they stimulate the release of insulin, so they do not cause hypoglycemia. The way that they cause weight loss is through their effect on the hypothalamus. The satiety center is located there. They stimulate the satiety center, reducing appetite, so the patient feels hungry earlier and stays hungrier for a longer duration of time. There's a reduction in GI tract motility and gastric acid secretion. It also increases the uptake of glucose through the skeletal muscle and the adipose tissue. Plus, it has the cardioprotection. This is how cardioprotection is achieved, is through decreasing the markers of atherosclerosis, the traditional markers, reduction in LDL triglycerides, increase in HDL, and reduction in the inflammatory markers, interleukin-1, 6, TNF-alpha. So that leads to an endothelium-dependent vasodilation, which has powerful pleiotropic effects on the heart. And also it has proven to be nephroprotective by increasing excretion of salt through the kidneys. So this is the landmark step 1 trial, which, as you can see, when the individuals who were randomized to semaglutide showed a significant difference in weight from baseline, and you can see the lines separating out right from the early stages, and that they were able to sustain over a long period of time in those who were given semaglutide versus placebo. So a dramatic reduction in weight loss. So the GI side effects, they always ask about side effects. They have all the right to ask about that, patients. So side effects are mostly GI in nature, in the terms of nausea, vomiting, a bit of diarrhea, constipation that most weight loss agents have actually. GI side effects are usually dose dependent. They will be there when you're starting treatment and up titrating the dose. They're usually mild to moderate intensity, and you can educate the patient to minimize these effects. So what do you need to educate them about? First, tell them that they can expect this. If patients know what to expect, they're more accepting of it. Otherwise, they'll feel, oh my God, what's happened to them? They'll stop the drug prematurely. And then you need to explain to them to have small meals, eat them slowly. They need to stop eating before they're full, otherwise they're going to throw up. So they have to avoid spicy food and fatty foods, oily foods, deep fried foods, and avoid lying down after having their meals. Otherwise, they're going to feel the food is stuck in their throat the next day. So people, if you advise them, they usually do well. Slow escalation. For instance, in the case of liraglutide, instead of a weekly increment, you can go for 2 weekly, 3 weekly increment. In the case of semaglutide, instead of a monthly increment, ask them to use the same dose for another month and then go up when they're better. In certain situations, they may need antiemetics or PPIs. So the other common complaints is generalized weakness with GLP-1 use. Family members complain, oh, they're unable to eat anything. You have to advise them. They've already had their excess calories over the years. So now it's high time they need to be in a caloric deficit state. And this is what they're helping them to achieve. And they need to have very small meals. They cannot stay empty stomach. Small meals over the day, spread over the day, in order to prevent them staying empty stomach, because that would also aggravate the nausea and become counterproductive. And plus, they need to ensure a good amount of protein in the diet that we talked about, the lean meat, the red beans, which are full of iron, protein, and need to engage in some form of resistance exercise, such as 1 to 2 kilograms weight, because that helps to preserve muscle mass. These are absolute contraindications: pregnancy, breastfeeding. Actually, if someone is overweight, obese, they should be advised to lose weight before they attempt conception, because a lot of complications can occur in pregnancy. But with adequate contraception, severe GI illnesses such as IBD, inflammatory bowel disease, absolute contraindication, history of pancreatitis, a personal family history of MTC, of course, you should not be given GLP-1. GLP-1 does not cause MTC. It has been shown to occur in rats, rodents, in the early phase 1 studies. But if somebody has a history, of course, it makes sense not to give it to them. Now, very briefly, the alternative weight loss agents, we don't have the naltrexone bupropion preparation here, available by the name of Contrave. You can have it procured through pharmacies. It is a dopamine reuptake inhibitor. The greater the amount of dopamine in the CNS, the happier the patient feels. Can be ideal for patients with, who are suffering from depression or want to stop smoking. This is an opioid receptor antagonist, which also promotes satiety. Phentermine, topiramate combinations, again, not widely available, and are an option for individuals without CVD or who do not have uncontrolled hypertension. Both the components stimulate norepinephrine, epinephrine release, and antagonize glutamate receptors, inducing satiety. For instance, if someone is suffering from migraines, this would be an ideal agent to give, and they're not wanting to have GLP-1 agonists. It's a very busy slide. This is just to show you these educational resources are very helpful with the rapidly evolving field, science. So all the new drugs that are happening, it gives you a very good description of how to start them, when to uptitrate, what are the adverse effects and precautions observed. Goals of weight loss therapy studies have demonstrated up to 22.5% weight loss. And these have been achieved by the GLP-1 agonists, GIP-1s, who have been able to achieve weight loss that previously was only possible through bariatric procedures when combined with lifestyle measures. This is instrumental. A weight loss medication to be deemed effective, it has to meet the minimal bar of having achieved weight loss of 5% of baseline over 3 months on a therapeutic dose and maintenance of that weight. It's very important to communicate to the patient that not every medication works for every patient. Responses can vary widely. When maximal effect is achieved, a plateau will happen. It does not mean the drug has stopped working. It just means additional strategies are required. And if you discontinue the drug, weight regain is likely. So obesity is a chronic disease, so long-term use is actually the key. It's just like an antihypertensive. You stop the blood pressure medication, blood pressures go up. Stop the statins, cholesterol will go up. Stop the medication, your weight will go up again. So metabolic surgical procedures basically are used when medical management and lifestyle measurements have not worked to the extent that you'd need. if the patient is having relentless OSA or rapidly progressive metabolic dysfunction associated fatty liver disease. The need for commitment to lifelong stages and lifelong changes in lifestyles and vitamin supplementation is important. And these are the various procedures. The more complicated the procedures are, the greater the weight loss, but the greater the side effects. We already talked about the effect of weight loss on diabetes remission and so forth. And I'd like you to leave you with the fact that obesity is should be recognized as a chronic disease. Pharmacotherapy in conjunction with lifestyle measures are instrumental. Most obesity medication need to be used on a long-term basis. Agents like GLP-1 agonists offer cardioprotection and should always be considered. So this is for the fellows. Basically, it's a patient with ischemic heart disease, pre-diabetes. He struggled with lifestyle modifications for a large part of his life. Given his metabolic syndrome and high CV risk, what is a suitable evidence-based intervention to reduce both events? Basically, it's a resounding start with GLP-1 receptor agonists with structured lifestyle interventions. Having said all that, prevention is better than cure, and we'll be discussing a lot about that in our panel discussion, I believe. I thank you all very, very, very much.
Thank you, Dr. Esra, for that comprehensive discussion on individualized management. And as very rightly pointed out, the management starts from our assessment. So our role is also very, very important in every patient.